Childhood discitis is a separate issue. Granulomatous diseases like TB, syphilis, and certain other bacterial agents, brucellosis, and then post-operative infections. The vertebral osteomyelitis, we have to discuss it because it's extremely important to differentiate this from tuberculosis. This falls in 2 to 8% of all cases of osteomyelitis, and most of them result from hematogenous spread with a source somewhere in the surrounding. Many times there has been a procedure in the recent past, like a week or 2 weeks back, in the pelvis or in the abdomen. And from there, the bacteria enters to the Barrett's plexus and they infect the spine. Most of the time, they are immunocompromised people, advanced age, diabetics, intravenous drug abusers, and they have sometimes they have chronic infection, and the infection from there they reach the spine. In majority of these cases, they are the Staph aureus, the organisms. The location in case of osteomyelitis, the commonest is the lumbar spine, followed by thoracic spine with 35%, then cervical, and the junctions, that is thoracolumbar and lumbosacral junctions, are not very frequently involved. Now, clinical presentation is like any acute infection. The symptoms will be very severe, sudden onset. In a few days, the patient becomes extremely painful, symptomatic, high-grade fever, and all the movements become very painful. It's just not possible to ignore that sort of pain. The constitutional symptoms are very severe. On examination, the patient in 100% of the cases will be tender. The movements will be painful. The SLR would be positive. In most of these cases, there is weight loss. And there is, if lumbar spine is involved, there will be hip flexion contracture because of the spasm of the psoas. In the case of the cervical, there can be torticollis, there can be dysphagia. In those cases where there is a subacute infection, the symptoms are not like the acute one, then it's difficult to differentiate that from tuberculosis. Now, in 4 to 17% of the cases, they end up with neurological sequelae, and the mechanism of that can be a direct neurological involvement by the bacteria, or it can be indirect compression because of the sequestrum, because of the loose bone pieces, and because of the abscess. And that can cause spinal cord compression. At the same time, there can be thrombosis in the vessels supplying to the spinal cord and cause neural ischemia, and that also can be a reason for neurological sequelae. Now, this is just a short algorithm. How do you, when you suspect infection, normally we start with the X-rays. The X-rays usually are negative in the initial phases. It may take up to 3 weeks for the X-rays to become positive, but CBC would have increased TLC, neutrophils would be high, the ESR, the CRP, they're all high in these cases. In the case of subacute infection, in case where the radiology is not very helpful, where the MRI is not very helpful, we can do MRI scans or even the technician 99 scans, the gadolinium scans. They all can help, but most of the time MRI usually would give you increased blood supply, increased hyperemia in that region, will give you a clue that there is infection. Now, in order to confirm the infection and to get the bacteria for culture sensitivity, we can do CT scan or image intensifier guided needle biopsies. And if that doesn't work, we can do open biopsies. Following that, we can start the treatment. Several people would empirically start with the antibiotics and see the response. And if it doesn't work, then they go for biopsy. But most of people, they would take culture first and then start the antibiotics. Now, management is the same for any acute osteomyelitis. You start with the broad spectrum antibiotics and then you change them according to the culture sensitivity. You can give up to 4 weeks IV. When the symptoms subside and there is reduction in the CRP, you can switch to oral for a total of 6 to 12 weeks. Then immobilization in the form of bracing would help. This will be very important because the patient has to be mobilized. You cannot keep him in the bed for a very long time. So with the bracing, it helps the patient to mobilize. Surgery is usually not indicated in the initial phases. It happens only when there is neurological deficit, when there is spinal instability, when there is impending collapse or there is deformity, when there are abscesses where drainage is important, or where the medical management fails and the diagnosis is in doubt, or where we suspect that it can be something else as well and it cannot be the infection. That's where we go for surgery. Let's go. Surgical management initially is depends on what you are doing it for. If there's no collapse and there's no abscess, there's no need for any surgical management. But when you see abscess formation, when you see deformity, when you see that there is infection, it's not responding to antibiotics, we can do debridement. Now, the debridement can be anterior or can be posterior or can be both. It depends on the location of the infection. One has to remember that in pyogenic infection, well, Staph aureus, they have proteolytic enzyme and they affect the disc in the initial part of the, in the initial course of the disease. And the disc is like a sequestrum part, a dead piece there. In contrast to this, in tuberculosis, they don't have pyogenic, these proteolytic enzymes. And therefore, the disc is preserved till the very late during the course of the infection. And therefore, in the pyogenic infections, one has to remove the disc because that is a source of infection. And then depending on the experience and depending on the location of the infection, we can go either from the front or from the back, or we can do both combined. Now, obviously, when we do debridement, we further disrupt the stability of the spine. So we have to restore the stability of the spine in the form of either bone graft or in the form of a cage, and then stabilization in the form of screws or rods, whatever we are used to, whatever implants we have. So the basic principles are stabilization and debridement. Now, this was just a short description about pyogenic infection. Let's go to the main topic, which is tuberculosis. Now, tuberculosis is a very old disease, and the earliest descriptions and the earliest remnants were found in the Egyptian mummies in the pharaoh's time, and that shows that the infection was still there even at that time. Now, most of the time, the infection is hematological from some other source, and that other source can be from the lungs, the body. The commonest area of infection, in contrast to the pyogenic, is thoracolumbar area, followed by thoracic, then followed by lumbar, and then the cervical. The most common area of infection is paradiscal. And why this happens, why it chooses the adjacent end place of two vertebral bodies, and the answer lies in the embryology. Embryologically, this part of the spine, which consists of a disc and part of the upper vertebra and part of the lower vertebra, they form one segment. And that segment has one artery as a blood supply. And later on, they evolve into a disc and the lower part of the upper vertebra and the upper part of the lower vertebra. but the blood supply remains the same. So when the organisms invade, they invade both the vertebral bodies. And that's why the infection starts in two vertebral bodies. Now, in 1/3 of the cases, there would be an evidence of tuberculosis. In 1/3 of the cases, if it is the lumbar spine, there will be associated psoas abscess. And in only 25% of the cases, you can see abnormality in the chest X-ray. Now, the signs and symptoms can be local or can be neurological, can be general in the form of constitutional symptoms, and can be because of deformity. Now, the constitutional symptoms, as we all know, low-grade fever, weight loss, malaise, body aches, evening temperature, they all may or may not be there. The local symptoms include tenderness and spasm in that area. And when the disease advances, it develops into a deformity. Now, that deformity can be in the form of kyphosis or can be scoliosis. Now, in later stages, the neurology is involved, and this can be in the form of a pain, which can be radicular or dysesthetic, or there can be sensory deficit, there can be motor deficit, there can be spasticity if it is in the above the L1 level, then there can be bladder and bowel involvement. Now, we have to understand that if the nerve root is involved, particularly in those cases where the asymmetric areas of the spine is involved, there can be symptoms in the form of radiculopathy. And it becomes difficult to diagnose that radiculopathy from degenerative diseases. And it's only after investigation and imaging that we find out that there is an infection in the spine. Now, Mantoux-Stokes test in the West is the first test performed. And if it is positive, that is a sign that this can be tuberculosis. But in our country, positive Mantoux does not have much importance because most of us are positive. However, if the test turns out to be negative, it's important because that patient might be immunodeficient. Now, ESR is usually elevated. ELISA for antibody to mycobacterial antigen 6, sensitivity is 60 to 80%. PCR sensitivity is 40%. And sometimes this can be confused with brucella, for which you have to do a complement fixation test to differentiate it from brucella. Now, when we talk about the diagnosis, when we take tissue for staining, the Ziehl-Neelsen staining, this is quick and inexpensive. However, the yield is not very much. In best centers, it can be up to 25%. Similarly, the culture results, again, are not very good, maybe 40, 45%, and it takes about 6 weeks. At maximum, it becomes 50% positive response. Nowadays, the GeneXpert test gives you a very good result within 48 hours and also tells you whether there is any resistance to rifampicin. But for that, you need fluid, you need pus. You cannot send the bone pieces or sequester for GeneXpert. Now, when we talk about the radiology, now the plain X-rays are the first investigations that we start with, but it takes several weeks before the X-ray would become, the lesion would become visible on plain X-rays. A minimum of 21 days are required. So we can do CT scan, we can do MRI. MRI is a very good investigation for diagnosis infection. Why? Because it doesn't only tell you, the first thing that happens in that area is edema. And this is what MRI would pick up. Then if there's abscess formation, MRI would pick up that. So even if the bone cannot be clearly seen and there's not much destruction of the bone, but the surrounding soft tissue edema and swelling, that can be clearly seen on the MRI and would give you an idea about the infection. Now, bone scan would show increased uptake in those areas where there's increased blood supply. If there is sequestrum, that would appear as a cold spot on the bone skin. Now, for the plain X-ray, more than 50% of the bone has to be lost and destroyed. Minimum of 3 weeks, may take up to 6 months. And the classical findings on a plain X-ray are decreased intervertebral disc height, and then the hyperemia in the paradiscal region, and then sclerosis in that region. Now, if you remember, we said that the disc remains intact till the very late stage in the infection. But in the X-ray, this is the first sign, loss of disc height. And why is it so? This happens because the infection is paradiscal. Now the end plates become so soft that the disc is more stronger than the end plates, and the disc actually protrudes into the end plates. Now the disc is intact, but on the X-rays, it will look like there is the disc height is lost. But when you open it up, the disc usually would be intact. Now the deformities, most of the time, is in the form of acute kyphosis. There's a wedging or there's gibbous formation. In severe cases, the whole of the vertebral body may be lost. It's called as vertebra plana. This is not a very common finding because this happens when there is a central lesion, not a paradiscal lesion. So whenever you see a vertebra plana, tuberculosis can be one of the differential diagnoses, and the other differential diagnosis can be an eosinophilic granuloma. Now, how you measure the degree of the deformity? So there are two ways. One is the kyphotic angle, where you draw one line along the posterior part of the vertebral bodies of the vertebra above the deformity, and then a similar line below the deformity, and the angle formed, which is called a K angle, a kyphotic angle, that is the deformity angle. The other is to draw like a Cobb's angle, the upper line along the upper end plate of the healthier vertebra, the first healthier, and the lower line along the lower end plate of the first lower healthier vertebra. And that gives you an impression about the severity of the deformity. You can monitor the progress of the deformity, whether this is increasing or it is static. And that would also help whether this patient is going to develop very severe deformities later. Now, CT can be helpful. The best information that it can give you is when you see calcification in the abscess. That is a hallmark of tuberculosis. Then there are certain regions which cannot be seen with the plain X-rays, like the junctional areas, where the CT can be very helpful. Then in posterior tuberculosis, that is infection involving the posterior segment of the spine, they cannot be clearly visible with the plain X-rays, and there also the CT is very helpful. Now, the commonest area would be a paradiscal. Then the second commonest would be a central lesion. Then the third commonest would be an anterior part of the vertebral body, and then are the posterior elements. The MRI is the investigation of choice and would give you the abscess formation, the hyperemia, the marrow infiltration, the discitis, the extent of the abscess, the flow of the abscess, the area where the abscess is going on. They all can be seen from the MRI. Ultrasound can be used to detect any primary in the abdomen or to find out any cold abscess. And you can use ultrasound guided aspiration to do the culture sensitivity and gene expert. Now, radionuclide scanning usually is not done. It's done in only those cases where the MRI is not very helpful. You can do technetium 99 scanning, and that will give you increased uptake in that region. It's a non-specific test. It doesn't give you confirm evidence that this is tuberculosis, but it shows that there is infection. And any lesion which is more than 5 millimeter in size can be detected with technetium 99 skin. Now, as we said, the commonest is paradiscal, second is central, third is anterior, and the most common are the posterior elements involvement. These are the anterior lesions, and obviously, when anterior lesions, there is collapse much earlier in the vertebral body, and there's abscess formation that moves anteriorly, and that can be seen on the plain X-ray as well as and the MRI. This is a central lesion involving the, now they're all atypical because the typical one is paradiscal involvement. So whenever you see central or a lesion involving only one vertebral body, you should always suspect some other disease as well, particularly metastasis in the case of middle age or aged people. Now the posterior column involvement, which is very, very rare but can happen. And the most common finding would be an abscess in the posterior part. And then you can see involvement of the bone in that region. And this is important to differentiate because when you are thinking about surgery, you need to know which approach do you want to use. And if this lesion is posterior, there's no justification of going in the front. Now, symptoms can be produced because of the cold abscess. And the cold abscess travel along the path of least resistance. So sometime in the cervical spine, you can see swelling or abscess in the front of the neck. Or it can track in case of thoracic along the neurovascular to the front of the chest. And there would be a swelling, a globular swelling in the front of the chest. And when you open it up, there would be pus. And when you do the investigation, you will find it's coming from the spine. Then in the mid-thoracic, anywhere below T4, the abscess usually would stay there in form of fusiform shape. Sometimes it tracks down the neurovascular and come to the front. And below the diaphragm, it usually develop as a psoas abscess, which may track down to the thigh or along the iliac crest, or it may stay there. Now, this is a huge retropharyngeal abscess. And these are psoas abscess that tracking down up to the medial thigh or going there to the Poupart ligament. Now, what is the differential diagnosis? Now, if it is a classical location, paradiscal, the only thing you need to worry about is whether this is acute infection or pyogenic infection or tuberculosis. But if it is not the classical one, then you have to differentiate it from pyogenic, from brucellosis. Sometimes neuropathic spine can also present in a similar way. And then neoplastic processes and metastasis disease can behave in a similar form. Lymphoma can also present in a similar fashion. And then sometimes degenerative diseases can be confused with tuberculosis. So whatever we do, the answer would be a biopsy and then culture sensitivity. Now, how to differentiate between pyogenic and tubercular? The most important would be the symptoms. In pyogenic, it's only a few days. In tuberculosis, it's long-lasting, long duration, may take few months. In pyogenic, there is usually the source in the abdomen, in the pelvis. There can be history of any instrumentation, any procedure in the pelvis or in the abdomen. In tuberculosis, usually there is a primary focus in the lungs or in the abdomen. The most common location in case of pyogenic is lumbar, while in case of tuberculosis is thoracolumbar spine. In case of tuberculosis, there can be multiple vertebral segments involved. Up to 5, 6, 7 vertebral bodies can be involved. In case of pyogenic, usually 1 or 2 segments, 1 or 2 vertebral bodies involved. Vertebral collapse is very common in tuberculosis because this is a very chronic problem. In pyogenic, it is relatively uncommon. Now, bone destruction is common in both. Posterior elements involvement is rare in both the cases. Skip lesions are possible in case of tuberculosis, but are very rare in case of pyogenic. And the disc is very infrequently involved, very late involved in case of tuberculosis, while this is the most early source of destruction in case of pyogenic. And paraspinal and epidural abscesses are actually present in both the cases. Now, a few words about the brucellosis. It usually involves a whole vertebral body. Collapse is very, very rare. The vertebral architecture is usually maintained, although there is osteomyelitis. The deformity is very rare. There is a small paraspinal abscess. You can consider this like a tuberculosis, but a more chronic form of tuberculosis. And the diagnosis, if you suspect it, depends on the location where brucellosis is more common. You can do the ELISA, you can do the complement fixation test and other serological tests for brucellosis. Now, how to differentiate from neuropathic spine? Neuropathic spine is a very difficult differential diagnosis. First of all, there would be reason for neuropathy. Either this is diabetes, syphilis, or the patient has got the traumatic cord injury, and the lesion is below that. In both, there would be destructive changes in the vertebral bodies. In case of neuropathic, there would be large osteophyte formation. There would be extensive vertebral sclerosis. There will be more hypertrophic bone formation. And the most important differential diagnosis, or the way which you want to differentiate, is through MRI, where in tuberculosis you will find an abscess, but in there would be no abscess formation. Now, in case of neoplastic, the neoplastic lesion can be primary or can be secondary. In the case of primary, it can involve either the anterior elements or the posterior, but it's never paradiscal. It usually involves a single vertebral body. In case of multiple myeloma or lymphoma or other systemic diseases, it can extensively involve the spine. But again, the picture is very unlike tuberculosis. The paradiscal involvement is not there. There is no collapse. There's no loss of disc height. In case of METs, the posterior elements are more frequently involved, and then you can find the radiological sign, which is called as missing beak or winking owl sign. Winking owl when one of the pedicle is involved, and missing beak when the spinous process is involved. This is a case of a central type of tuberculosis, and if you see there is central involvement, there is severe hyperemia in the surrounding areas. And such sort of lesion you will like to investigate for any other pathologies. Now, sometimes the congenital anomalies can be confused with tuberculosis. For example, hemivertebra, or when there is a defect in one of the vertebral bodies. But again, the sign and symptoms would not be there. Deformity can be there. And the CT scan and the MRI, that would help in the diagnosis. Schurman's is a totally different sort of disease, but sometimes can be confused in adolescents. There is diffuse involvement of the spine. There is diffuse kyphosis. In case of tuberculosis, there is acute kyphosis. This is more rounded. The age is in adolescent, in the 15 to 25 years of age, and small nodes are there. systemic signs are not there, ESR, CRP are normal, and there is no progression, and the tenderness and all those symptoms are not there. Now, once you have a diagnosis, then how to treat? Now, before the antibiotic area, before the rifampicin was invented, uh, the treatment would be conservative, and later on in in the middle of not in the middle, the last decades of 1900s, the laminectomy and laminotomy were started. Castrotransvasectomy was started by Menard. Now, they were like incision drainage procedure to drain the abscess, and that would reduce the pressure on the spinal cord and would help. Now, laminectomy is now a contraindication in case of anterior tuberculosis. And why? Because in anterior tuberculosis, the posterior elements are a source of stability. And if you do laminectomy without stabilization, that posterior stabilizing structures are also compromised, and the spine becomes more unstable, more deformity, more chances of neurology. So it's a contraindication to do laminectomy in case of anterior column involvement. So after the laminectomy and laminotomy, castrotransvasectomy was another one, and this castrotransvasectomy is still done. There is we go from the transverse process, and we go along the lateral part of the vertebral body, and the whole abscess is there, and we just drain the abscess. Now, the debridement is not done. The sequestrum is not removed, and therefore, the deformity cannot be corrected. The deformity cannot be prevented. Similarly, lateral tracheotomy, again, started by Kapner in 1933. Again, we cannot do a very good debridement. This is done from the posterior approach. And we cannot prevent deformity. We cannot correct deformity. And finally is the anterior debridement and fusion, and then the combined anterior and posterior debridement and fusion. So when the most important question would be, when would we like to go for surgery? What will be the surgical indications? Now, the surgical indications vary from center to center, and also depends on the facilities available and the expertise available. Now, generally speaking, if the infection is suspected, and you are in an endemic area where most of these patients where you suspect tuberculosis would actually be tuberculosis, most of us, they would start with empirical chemotherapy, and the patient usually would improve, and that would be a sign that the diagnosis is tuberculosis, and we would proceed with the chemotherapy and treat it with chemotherapy. And we would go for surgery only when there is abscess formation, when there is deformity, or when there is neurology. When we start with chemotherapy and the patient does not respond in a reasonable time, and that reasonable time would be about 6 weeks, and there is no improvement in the constitutional signs and symptoms, that will be a point where you should worry about your diagnosis, and you should think about taking biopsy. There are many centers who will not start chemotherapy until they do the needle biopsy and take the sample for histopathology as well as the culture sensitivity, and they will do it only after the results are available. But as I said, it varies from center to center. But generally speaking, whenever there is neurological symptoms, we should go for surgery. Whenever there is deformity, we should go for surgery. Whenever there is doubtful diagnosis, we should go for surgery. Whenever the chemotherapy is not working in the first 6 to 8 weeks, we should go for surgery. And finally, when the disease has healed and there is paraplegia of late onset because of the deformity, that's where we should go for surgery. Now, transvasectomy, that's how we do. We go through the posterior approach. Remove the transverse process, remove this part of the rib, which is attached to the vertebral body. And once we remove that, the abscess usually would gush out. It's usually under pressure, the abscess would come out. And that's all we can do in this approach. It's usually done in those cases where there's a big abscess, there's not much deformity, and the patient is immunocompromised. Either patient is in extreme ages and he is not fit for a major surgery, and we need to drain the abscess. The Kapner lateral rachotomy is a more, you can say, advancement in the costotransversectomy, where we not only drain the abscess, we also remove part of this half of the vertebral body, where there is sequestrum, there is dead bone, avascular bone, we remove that, but we cannot remove the whole of the vertebral body, and therefore we cannot prevent the deformity, we cannot treat the deformity. Now, this is one of our patients. This was done 20 years back. And if you see, there is a 64 degrees of deformity. Why would a patient have 64 degrees of deformity after the surgery? It's only because we did a Kapner's anterolateral decompression. We were not able to correct the deformity, and the deformity persists, rather it increased with time. There's just 2.5 months after the surgery and there is such a severe deformity. So it's done only when deformity is not much of our concern, if we need to drain the abscess. Now the Hong Kong operation, the famous Hong Kong operation, this was started in Hong Kong in 1952 by Hodgson. And much before that, actually, this procedure was done in animals, in horses, and it started from there. So the Hodgson started anterior debridement, and initially they used ribs as a strut graft, and they would use a plaster of Paris jacket to immobilize the spine, and that's how the picture is. The problem was the rib graft was not very strong. Sometimes they will fracture, they will collapse. And therefore, later on, they started using strut iliac crest tricortical grafts with that. In the late 90s, the people started using cages, titanium cages, metallic cages, which is filled with bone graft, and that provides much better stabilization. This is, again, one of our case where we did only the anterior debridement. This is a pre-op picture. And this is 9-month post-op, and this is the only debridement was done. You cannot see the graft because this is a tricortical iliac crest graft. And this is well incorporated. The deformity has not progressed, and the disease has healed after 9 months. However, this is not the case in every patient. This is, again, another of our patients which we operated in the 80s. And you can see the rib graft there. And this is 6 months post-op, and you can see the deformity is there. And actually, we corrected a very good amount of deformity in this case. But as I said, the grafts are not very strong, and the deformity usually progresses. This is another of our case where we use the iliac crest graft. And immediately after the surgery, you can see the graft here. And the deformity was only 20 degrees because we corrected the deformity. But if you see 6 months down the line, the deformity has progressed to 40 degrees. So only the grafts are not very good in preventing the deformity, and the deformity is a very important aspect of management. You can see the same patient, and it has gone up to 38 degrees. So it's because of the weak bone graft. That's why it loses the strength and it goes into kyphosis. This is how we do it. These are the lengths, anterior approach, thoracic, and this is the debridement. The crater is produced, and this crater is filled with the bone graft. bone graft. Now, this is the titanium cage that we started using. And this is filled with the bone graft, and that area, with the raw area, the crater which is created, that's filled with this bone graft, the deformity can be partially corrected. Up to about 30 degrees, the deformity can be easily corrected and can be prevented. But if the deformity has progressed by more than 30 to 40 degrees, it's very difficult to correct that deformity with only anterior approach. In that cases, we have to choose both the anterior and posterior approach if you want to correct the deformity. Now, this is one of our patients, and if you see, this is a T1 wedge image, and two vertebral bodies and intervertebral discs are involved. You can see in the plane X-rays here, the disc is involved and both the end plates are involved. And the cages, we thought, is a wonderful discovery because they were very strong. They would prevent the collapse of the vertebral bodies. And we thought we got a solution to the collapse and the deformity problem. And if you see here, we have used screws. And why we have used screws and rods? Because in lumbar spine, the cages are very stable in flexion. But in extension, the cages are not stable. And that's why we have to use these screws and compress. So if there is extension, it happens not in this segment, it happens in segment below the fixation. And that's why the implant stays stable. However, now this is another of our case. And if you can see, this is 1 year follow-up and there's no deformity and the disease has healed. This is a cervical spine case. You can see there 5-6 tuberculosis with an abscess formation here. And again, anterior debridement and graft and anterior plate fixation. But then, soon after we started using a lot of cages, we realized that there are a lot of problems also with this. This is not the ultimate solution to the subsidence problem, to the deformity correction issues. You can see the cage can actually subside into the bone, particularly in osteopenic areas. The cage can actually displace, and if it displaces, it can go in the front or it can go in the back. And when it goes in the back, it compresses on the spinal cord and can cause neurology. Now, this is another one. You see, this is few months down the line, the deformity has progressed. And as we said, if you use the cage alone in severe deformity, this is what is going to happen. So in cases of severe deformities like this, it's mandatory to use both the anterior and posterior approaches and use the cage as well as posterior stabilization. Only then you can prevent the deformity. Otherwise, this cage becomes even more dangerous. Now, cage migration, you see the screws have all now angulated. The cage has gone up to the disc space and it has migrated posteriorly, compressing on the spinal cord. And removing the cage also is not an easy job. Now, in case of severe diseases, in case of neglected tuberculosis, it may not be possible to use only the posterior, the anterior approach. The solution would be to use both columns, debridement and stabilization, both anteriorly as well as posteriorly. Now, the disadvantage of this approach would be that we will have to use two surgeries. First, we will have to go through anterior, do the debridement, cage formation, fixation, and then go to the back. Again, both are major surgeries. Recently, we have started using the posterior approach and we do both anterior and posterior through the posterior approach alone. This is one of our case in which we use the posterior approach. We have gone along the side and we have done the bone grafting here. This is a T3-4 tuberculosis, and here we did only posterior stabilization. And if you can see, this is done when the deformity is not severe and the patient is very symptomatic, there is severe pain. So with stabilization, the mechanical part of the pain is taken care of. The deformity does not progress, and usually it stays there. This is another, this is 2L1-2 tuberculosis. And here you can see we have done posterior stabilization alone because there is not much deformity in this area. Now here we have done combined anterior and posterior approach, and you can see the graft in that region, and you can see the screws, and this is only to the posterior approach. This is another of our patient, 12 years, and you can see abscess formation, you can see paradiscal infection, and you can see the epidural abscess formation here. And there is deformity, and in this area, particularly in the T12L1 area, if you want to go through the front, we will have to go through the diaphragm, which has its own morbidity. Now, although most of the people would like to go through the front, we usually would use the posterior approach and would address both the anterior column as well as the posterior column through this approach. And that's how we do it. You can see the fibular graft that we used, and only posterior approach, debridement, remove the vertebral bodies, use the fibular graft, and in the same setting, use the pedicle screws, and both the anterior and posterior stabilization is done. Now, this is in case of severe deformity. If we use only anterior approach, it's not going to work because this deformity is going to progress. So in this case, we have used the posterior approach, and we have done both the anterior vertebrectomies. We have removed 2 vertebral bodies and the disc spaces, and used a cage from the posterior approach, and then augmented that with the rods and the screws. And you can see we have achieved considerable correction of the deformity. This much deformity cannot be corrected with only anterior or only posterior approaches. Now, this is upper thoracic. Now, if here we try to use the anterior approach, we will have to mobilize the great vessel, the aorta, and all the major vessels in that area, which by itself has major morbidities. It becomes a lot more easier if you go through the front, do anterior column debridement, put a cage there, and then augment it with posterior stabilization, and without the need to mobilize all the anterior major vessels. This is again one of our patient, 30 years old, and he presented with the gibbous in the upper thoracic spine, which again is a difficult area for only anterior, and there were early signs of the neurology. And if you can see the x-rays, there is collapse of the T4 in this area. And there is a huge abscess formation. This is probably T3-4 area, and there are 2 vertebral bodies involved, and there is a good amount of deformity, and you can see the sequestrum which is pushing on the spinal cord, and that's why this patient had upper motor neuron signs. Now, if you want to go from the front, we will have to go through the sternum, and we will have to mobilize all the major vessels. It becomes a lot more easier if you go from the back and do both the anterior and posterior decompression stabilization through the back. And that's how it looks, and you can see the tricortical graft in this area. Now, this is lumbar area. Again, the problem with the anterior approach in lumbar area is if you want to reach to the spine, we will have to go through the psoas, and inside the psoas are the lumbar plexus or the nerve roots which are hidden. And in the presence of a big abscess and all the sequestrum, sometimes we might damage the nerve roots. And you damage any nerve root in the lumbar spine, it carries considerable morbidity. So it becomes a lot more safer if you go from the back and do the anterior and posterior debridement and stabilization, like this. So we can actually do all this debridement and cage fixation from the posterior approach and then stabilize it with pedicle screws in the same setting. Now, a few words about the paraplegia of late onset. This is more common in children. The infection is treated either conservatively or operatively, but in both the cases, the growing centers of the spine are damaged anteriorly. While the posterior part of the spine is intact, it keeps growing. And even if the infection is healed, the deformity would still continue to progress and may later on develop acute neurology, which is very difficult to treat. It's usually gradual onset. The first symptom is usually loss of balance if it involves the area above the L1, which is the spinal cord, and all the upper motor neuron signs become positive. Conservative treatment in these cases usually is not very effective, so we have to do surgery. Now, what to do in surgery? The goal here is not debridement. The goal here is to remove that part of the bone which is actually putting pressure on the spinal cord. And that is the apex of the deformity which is there. So unless we do kyphectomy, that is excision of that apex of the deformity, the spinal cord would continue to be under pressure. So we have to do kyphectomy in that case, correct the deformity, and then stabilize it, and only then this is going to work. Now, the role of post-op ATT is controversial, and just like any other musculoskeletal tuberculosis where we want to use implant and we want to operate, it is not a bad idea to give a 3-month course of ATT after the surgery. Now, I've shown you this X-ray before. This is how it looks perioperatively because it's such a severe deformity. So you have to remove all the posterior elements. You have to remove all the vertebral bodies, and this is the posterior approach. So both the 3 vertebral bodies have been excised. You can see the nerve roots, which are all visible. Now we will put a cage between these nerve roots, stabilize it, and then apply these rod and screws and correct the deformity as well. And that's how it looks. This is T4-5 tuberculosis. Now this is tuberculosis of healed, of late onset. This is a young lady, 35 years old, and she had tuberculosis when she was a child. And at that time, like 40 years ago now, posterior decompression and stabilization was done in the form of a rush nail and cerclage wiring. And you can see the remnants of the cerclage wire, although the rush nails have been removed. Obviously, they were not very good stabilization. The anterior elements continued, they were damaged there. The posterior elements continued their growth. And this patient developed problem at the age of 35, although the infection happened at the age of 10. This patient presented to us with severe pain and an inability to walk and claudication. And this is the CT scan. You can see there is acute gibbous formation here, and this part of the bone is actually compressing the cardia equina. And unless we excise this part of the bone, this cardia equina is not going to be at peace. So only debridement is not the solution here. We have to do a kyphectomy. Once you do a kyphectomy, you have to restore the stability of the anterior spine. And then if you have done only anterior, that might be sufficient. But if the deformity is severe, you will have to augment that with posterior stabilization. And we did it all from the back. So we excised the kyphus, removed those 2 vertebral bodies, replaced it with this small cage, and then stabilized it from the back with this. And this is the scar. And this patient started walking within 6 weeks after the surgery, and she improved, the deformity improved, the pain improved, and she was a happy lady. So now, due to the development of anesthesia and implants, we can do all these fancy type of procedures, combined anterior, posterior, using only posterior approaches, or all the anterior debridements. For this, you need a good setup. You need the human resource, trained human resource, as well as you need the ICU facilities, you need the implants, you need very good anesthesia. So the indications for surgery and the objectives for surgery, the goals of surgery would vary from center to center. And in very good centers, you may like to operate on all these patients. In centers where the facilities are not optimum, you may like to reserve your surgery to those cases where there is neurological involvement, where you may do just the drainage procedures and then refer them patient to some other centers. Now, thank you very much. If there are any questions, I would love to discuss it with you at this time.
Assalamu alaikum, sir. Assalamu alaikum, Professor Arif, and assalamu alaikum, Dr. Munawar. I have a few questions. If
Yes.
I have at least 4 questions, so should I progress with one at a time,
Yes.
or should I just
One at a
ask
time.
them?
One at a time.
Okay, sir. So, sir, first the investigation. So the first question was, how soon can an MRI be done? Because you said that the changes which we would see on the X-ray would be delayed at least to 4 weeks, right? So how soon? Isn't it better to directly go for an MRI because where we could see fluid changes?
You see, it's better to follow the SOPs. Now, the tuberculosis is a chronic problem. You don't know when the disease has started. The patient has come to you when he has become symptomatic, but the disease actually has started long ago. So you would like to start with the X-rays. And I can tell you then in 80 to 90% of the cases, you will be able to diagnose the infection. It is only in the initial few percentage of cases where you would need MRI. Now, MRI is expensive, number one. Number two, it doesn't give you all the details about the bony pathology. It is very good in detecting the hyperemia and the edema and the abscess, but may not show you all the bony destruction very well. So it's good to follow the SOPs, do the plain X-rays, and if nothing is visible, the X-ray would still be helpful because you can compare later those initial X-rays with the later follow-up X-rays. It may not be a good idea to use initially the MRI and then follow it up with X-rays and compare the MRI with the X-rays.
So can I ask a question, sir? What is the role? Do you do any endoscopies in spines?
We do endoscopy.
That help in diagnosis?
Yeah, not for diagnosis. For diagnosis, they need the CT scan guided or the image intensifier guided procedures are sufficient. Endoscopy is basically for decompression. So if there is discitis, we can actually do endoscopic debridement. If there is not a very aggressive infection where you would like to open it up, in case of mild discitis, you can go endoscopically and do the debridement. You can take the tissue for culture as well. And you can do decompression also.
So the reason I asked that question was that, you know, in our patients, in our criteria here, we do a lot of MR scans for instability work in shoulders, and they have pacemakers, they have claustrophobia, they're too big for the MRI scan. So in those cases, we have recently started what is called needle arthroscopy. It's a diagnostic procedure. Instead of doing MR scans, we put under local anesthetic in the clinic into the shoulder and have a look. We can do them in elbows, wrists, and knees. So that's why I asked. Otherwise, you know, I mean, if you can get an MRI scan, it would be an ideal thing to have for these patients.
Yes. So as I said, in 90% of the cases, the X-ray would be sufficient.
Fantastic.
If you even like to go for MRI, you may want to go for MRI just to see whether there's abscess all around, but you don't need to see the abscess in all the cases. If you see there is neurology clinically,
yes,
and if you see that the patient has all the signs, symptoms of tuberculosis, and the patient is developing neurology, you may not like to waste your time and waiting. And you just go in and do the decompression, take the specimen for histopathology and culture, and stabilize. So even if it doesn't turn out to be tuberculosis, it turns out to be something else, you still have done the right thing, because even if it was METS, even if it was something else, you would still like to do the debridement because there was spinal cord compression, and you would still like to do the stabilization because there was instability. So in those cases, but not in all cases, you may like to do the endoscopies. The gold standard is the needle aspiration, the CT guided or the image guided biopsies.
Okay, Shahzaib, you were asking a question.
Sir, my second question is just like Sir mentioned right now that when you need to go for a surgery, right? We're not sure, like Sir mentioned, that there is no diagnosis. The patient has not responded to any ATT, and the patient has developed neurological symptoms. So Sir mentioned that we should directly go for a surgical intervention. But my question here is, if, for instance, it is not tuberculous, because we don't have a diagnosis or any biopsy, so when we put in an implant plus the debridement, wouldn't it cause worsening? Because if it is pyogenic, I don't think, or maybe I'm wrong, that can we put in implants in a pyogenic abscess?
Now, this is a very common question. Everybody asks this. There are many studies now that have shown that even in pyogenic infections, titanium implants produce very good results. Now, the incidence of that biofilm formation is low in titanium as compared to stainless steel, and stabilization by itself support the cure of the infection. So even if it is pyogenic, as we discussed in the early part of this talk, even if it is pyogenic, even if it is confirmed pyogenic, you still would like to do the debridement. And once you remove all that bone, you will have to stabilize. And the only way to stabilize it, to use an implant. So we always use titanium implants. We always use pedicle screws for stabilization. This is not an issue in case of tuberculosis or infection of the spine.
Yeah, so I agree with you, Arif, that because a stable infection is far better than an unstable infection. We do quite a lot in here also. If it's infected, we make it stable, and therefore it does get better. Okay.
Yes.
So Shahbaz Saab, you have another question, is that right?
Yes, sir. So my third question is, in costotransversectomy, when we do it, we just go in and decompress on a single side, like on a lateral side, maybe on the right or the left, either of the side. So, but that does not mean the whole abscess is coming out. We only get partial part of the abscess. So the debridement isn't complete, is it?
Costotransversectomy is just abscess drainage, incision drainage, you can call it. And you can just remove this, you can just suck the abscess. Usually, whenever there is neurology, there's a lot of pus there. So the moment you remove the transverse process and the rib, the pus would come out, gush out, and the pressure would be relieved. So even if you don't remove all the pus, the pressure is still relieved, and the patient symptoms would improve. But that's all you can do with this procedure. You cannot do complete debridement. And you have to remember, if you do complete debridement, you have created a crater. So you will have to stabilize it as well. So this all is not possible with the costotransversectomy or with the anterolateral dichotomy.
So the answer to your question, Shahbaz, is that you have to have the indication right for doing this procedure. It is not valid for every procedure in tubercular spine. It's got a limited indication, as Sir said, that it is like an incision drainage. So you have to have a specific indication to use this. Anything else, and you have to go bigger, and you may have to debride and then stabilize. Does that answer your question, Shahzaib?
Yes, sir.
Okay. So your final question before everybody else gets in then.
So my final question is the role of steroids, and whenever a patient immediately develops neurological symptoms, so how acutely are we supposed to give steroids just for the neurology when we don't have a diagnosis, whether it's TB or pyogenic? That's my final question.
You see, again, it depends on the facilities available. If the facilities are available, you won't like to wait for the diagnosis. Whenever there is compression on the spinal cord, the answer is decompression. Whatever the pathology is, whether it's infection or it's malignancy or it's METS, or whatever it is, or it's trauma, disease, whatever it is, whenever there is compression on the neural tissue, you have to decompress. So there is no point in waiting So the steroids you can give only when you know that there is an infection that in which there can be edema playing a part, and you don't have the facilities to operate on that patient right away, and you want to gain some time, you can start steroids. The role is still not very clear. Sometimes it can backfire too. There can be a lot of side effects of steroids. So the answer is, if you don't have the facilities and you cannot refer that patient, you may give steroids to gain some time. Otherwise, it's not an answer to your problem. The answer to the problem is decompression and stabilization.
So the evidence supports that steroid does not do anything. Steroid is a diagnostic test. It is not a therapeutic test. If you give them anywhere where there is pain, it stops the inflammatory process, and therefore the pain gets better. In this condition where there is pressure and you want to relieve it, the swelling will go away, but it will come back in a bigger way. So the rebound phenomena from the swelling coming back is a lot more dangerous than actually getting the benefit. So like Sir said, you need to have the facilities, send it to a person who can, and decompress it and stabilize it, and that's your option. You can't buy time. And I keep saying that in Pakistan, you all do polygamy, you want to do everything. You shouldn't. You should be referring it to your nearest specialist center to get the best benefit for the patient. So anybody else has questions? So everybody's gone quiet. Nobody else has a question?
So nobody's asking a question. Can I add a question to that part?
Yeah, you're the only one awake, Shazib.
Sorry, sir. So my addition to that question is, for instance, we operated on a patient who had no neurology prior to the surgery.
Okay.
And then he developed neurology acutely right after the surgery. And could it be just, could there be any role of steroids then?
Again, why you want to use steroids? If the patient has developed neurology after surgery, obviously the surgeon has done something wrong that has induced the neurology. So find out what wrong has been done. Most of the time, it's the implant which is compressing on the spinal cord. So you immediately have to undo that and decompress the spinal cord. This should not happen. Patient was neurologically intact, and you operated and he developed. This is extremely rare, and there has to be some problem related to surgery. The other question is, why did you operate on that patient? If the patient did not have neurology and the patient did not have deformity, why you wanted to operate? All you needed was to take specimen for culture and sensitivity and diagnosis, and you continue with chemotherapy. And in case of early diseases, most of them would respond to it, and there would be no deformity and no neurology. So your indication has to be according to the situation.
You know, I agree with you. One of the indications in a radial nerve palsy is if it happens after surgery, you have to explore it. If it happens before surgery, you can live with it. But if it happens after surgery, you cannot sit with it. You can't give steroids. You can't do everything. You have to go and explore it. I agree with you completely. Yeah. Is that okay? Everybody's happy? Should we call it a day? It's getting late in Pakistan.
No, thank you, sir. Thank you.
Okay. Great, guys. Thank you very much. Bhatti Saab has just joined us. Arif Saab, Alisuddin Bhatti Saab. So he wanted to check on you, maybe. That's what he wanted to do. Anyway, thank you, sir. I'm very, very grateful. Hopefully, you guys will do your MCQs. I think it's in a couple of days, isn't it? So best of luck for MCQs. I will be coming to Pakistan soon. So hopefully, we will continue this teaching from Pakistan. I will bring a lot of slides and we can talk. But yeah, inshallah, we'll see you in Lahore, sir. I will see you in Lahore soon.
Okay.
Thank you very much, everybody.
Don't forget in the morning to prepare that MOU.
Yeah, thank you very much, sir.
Thank you.